Did they tell you how that would happen? It's like really interesting to know.
Alright guys, let's start. Relax. Things that we're gonna talk about. Got this. Okay. Trauma, drama. Oh, really quick with neuro, you do not need to know, I won't test you on GB, Guillain-Barré. So you don't need to know about that, okay? You probably should know it in real life, yeah, but I'm not going to test you on it. You already have too much stuff. Okay, so trauma, drama. We're going to be talking about burns and mass casualty today, okay? I love trauma. When I work in FLAG, it was a requirement that we all had our ATCN, that certification. It is the most fun certification I've ever taken before. Highly recommend. I wanted to keep it current, but Banner's like, no, you have to pay $700. And I was like, is it really worth it if I'm not going to be using it? But it's super, super fun. People, you get trauma certified. People come in and they're moulaged, meaning that they have like makeup and injuries that you have to identify and then talk about your treatment. It's so, so, so fun. So I love trauma. Trauma, I did that a lot in FLAG because despite what people think, we are a level 1 up there. Clearly in Banner, we are level 1 as well. I don't go to traumas. I've been down to the trauma bay to cannulate people, but the trauma ICU people are the ones that are certified and they go to trauma call, okay? So when they're announced overhead, if anybody's been at Banner, you guys will hear trauma red or trauma yellow. Trauma red's worse, trauma yellow is not, and they report that. Okay, so let's talk about mass casualty events. So with mass casualty events, there's 2 different categories, okay? There's an internal disaster and external disasters. So internal disaster, give me an example of an internal disaster that your hospital could be. What is this?
Shooting.
A shooting, oh okay, I was like, what are you pointing at me for? Okay, so sure, that would be the worst thing ever, a shooting, okay. What else? What's another less hypochondriac thing that I have to be thinking about? Okay, a fire. Yes. Okay, fire. We've also had issues where power. There's a power outage somehow, right? Oxygen supply. We've had issues. People have had issues with oxygen supply. So again, internal disaster is something that happens internally in the hospital. Okay, an external disaster is out in the community. Okay. There's different levels. So again, why this matters is because this is going to tell us how many patients the hospital is going to have an influx of, right? So level 1 is an apartment fire, right? It's one building, there could be several casualties, several patients, but it's going to be different than a mass shooting or a whole building collapse, okay? So again, different differentiations. Level 3 is the most. That's where we had the COVID pandemic, okay? So, for example, during COVID, right, Arizona was especially hit hard. I don't know if you guys remember, that was like 100 years ago, right? We had such an influx of patients that they created like a coalition in the state where they basically triaged COVID patients to go to different hospitals throughout the valley, so one hospital didn't get inundated with them, okay? Especially because what was happening is in the north, right, Flagstaff Medical Center is one of the main hospitals in the north, right? So all of the reservations where they were hit particularly hard were sending all of their patients to FMC, and they were incredibly getting inundated, right? So they did this huge coalition where they would help to alleviate the influx of patients, okay? So this also happens, speaking of internal disasters, right? Let's watch this. Teacher play.
Look at this. At a time when hospitals need every single bed and every square inch that they have, closing down an entire emergency department is not what anybody needs, but that is exactly what happened today at Banner University Medical Center in Phoenix. Mitch Carr is standing by with the latest from 12th Street and McDowell.
When was this?
The emergency department of Banner University Medical Center
Couple of years
is right
ago.
over my shoulder, and so are multiple trucks from CRS, that is Comprehensive Risk Services, and they specialize in water damage restoration, and they're needed because the emergency department is completely flooded. Here's a look at the water flooding the first floor. Pictures show it's about enough water to cover your shoes if you were walking in it. Banner Health says a pipe burst Friday afternoon. The water covering the floors is clean water according to the hospital system. Banner Health says the emergency department will be closed through the weekend as they work to fix this mess. Banner Health tells us that walk-in emergency patients will be admitted. They will not be turned away, but they will have to be cared for in another part of the hospital until this process is finished. In Phoenix, Mitch Carr.
So this is an example of a internal disaster. I was working that day. I was charged, and I was helping in the back of the unit, and one of my friends was like, Kels, what's going on outside? And I was like, what do you mean, what's going on outside? She's like, well, did you see the river? And I was like, river? What are you talking about? So from the emergency room, it looked like the Mississippi River, like just flooding out. And I was like, oh my gosh. And then they announced it overhead, where they said all available personnel come down to the ED. I did not want to go down because I did not want to get my feet wet, but of course I was forced to go. But I will say that in general, for something as terrible as that happened, to move all those ED patients out to a dry area, all of the C-suite people, the people that are in charge of everything, CNO, CMO, Chief Nursing Officer, Chief Medical Officer, all of those people came down in their suits to help. Our CNO had high heels on and what are they called? Not tights, pantyhose, and she was drenched. Her skirt was wet, and I was like, that's disgusting, but thank you so much for your help. So again, it was very cool to see people come together. Terrible situation, absolutely terrible. I was walking out that night and I saw that news reporter. He tried to talk to me and was like, were you involved in it? I was like, I can't, I gotta go home, I gotta take a shower. And he's like, please, do you have a comment? And I said, absolutely not, no comment. So I found the clip because it is a perfect example of an internal disaster, okay? Where we have to mobilize, and we couldn't turn away people. We can't turn away traumas. We can't turn away ED patients, right? But we had to mobilize and move people. It was a whole process. So that's a great example of an internal disaster. Okay, so let's talk triage.
Could they reroute new ones coming in though?
Totally, yeah. So if they called and if they, we could let them know to try to go to St. Joe's, for example. Yeah. But if they showed up, we couldn't turn them away. We couldn't say no, you need to go somewhere else. Okay, so let's talk triage. So in trauma, there is a tagging that happens, right? A triage process. And there's different colors, okay? Red is your first priority. Red are those people that have the life-threatening, but they are survivable. They're potentially survivable. But the caveat to that is they need rapid treatment. They need help right now, okay? So the red people require immediate intervention. Life-threatening, so, if you don't do anything, they're going to die. But if you do give them treatment, they will hopefully survive, okay? Yellow is second priority, right? Yellow is second priority. These are serious injuries, okay? Serious injuries that do require treatment, but they can tolerate some delay, okay? Condition is stable, and I underline for now, okay? Stable in quotation marks, for now, okay? Green is the third priority. That's what we call walking wounded, okay? These are the people that have the minor injuries, right? They're walking around and they have an abrasion on their shoulder, right? They can be delayed hours to days with treatment, okay? And then the black are the last. Those are people that are either deceased already or their injuries are so severe that survival is unlikely, okay? Unlikely. These people, we need to understand that the resources need to be directed to someone else, okay? When we're talking about resource dispersal, okay, they are going to go to the people that have the greatest chance of survival. Okay, greatest chance of survival. Even though this could be life-threatening, with treatment, they could survive. Okay? Questions about triage and how you look at it. Okay, let's practice. Okay, so let's triage these injuries. Okay, tension pneumo. What do you guys think? Red, yellow, green, or black? Red, right? Medical emergency, right? We talked about it. They need something right now or they're going to arrest, okay? Just hand really quick. What treatment would we do? What could you do something really quick? What could you do to help? Needle decompression, exactly, absolutely, okay, great. Massive head trauma with brain matter exposed. What color? Black. Brain matter exposed, never good, right? So yes, we would classify that as black. Long bone fractures, closed. What do you think?
Green, green to yellow.
Ooh.
Depending on which bone it is.
Okay, so a long bone fracture, let's say femur.
Yellow.
Okay, yellow. Okay, yellow. We absolutely need to do something about it. It's closed, right? It's yellow. It's not green, right? They can't walk around. They're not walking wounded. We can't delay for hours to days, right? So we need to do something about that, okay? Wrist fracture. Green, perfect, good job. Walking around, their wrist is broken, good. So if they don't get it for a day, they're not going to die, right? Burns, okay, we're gonna talk about this. Yay for burns. Burns not involving the airway, and then less than 20 to 40% of TBSA. Yellow, exactly. Now, if it said involving the airway, red, exactly. Okay, perfect. Open chest with shock. Red. Okay, so open chest with whatever that means, gunshot wound or stab, who cares? But the shock, that's going to elevate it to a red tag because we need help right now, immediate treatment, okay? What kind of shock would that be? Hypovolemic, yes. Specifically hemorrhagic shock, right? They're bleeding. Not all, I shouldn't say that. Most traumas, if you're dealing with shock, you're dealing with hypovolemic shock, specifically hemorrhagic shock, okay? They're bleeding, okay? So far, this guy totally could have hemorrhagic shock, right? Not this person, this one, yes, shock, okay? This one, Burns, could have hypovolemic shock, right? Okay. High cervical cord transection with apnea. What do we think? So transection means chopped off. Black. Yes. They're not breathing. Their spinal cord is severed. It's black. Okay. So 90% full thickness burns. 90%, I'm talking about their total body surface area. Black. Yes. 90% black. Yes. Unstable pelvic fracture. Yes. Good. Okay, good job, you guys. That was excellent. Okay, so let's talk about primary survey. Primary survey is king in trauma. What is the primary survey? I want you to type it out, okay? I want you to tell me what each of the letters stand for. That should be a hint. What is your primary survey? Each trauma that comes in, each trauma patient, you will do a primary survey, irregardless, okay? 4 people know, oh, 5. 5 people know what the primary survey is.
All that crap.
Okay, we're pretty good. Missing some letters down here, but that's all right. Oh, okay, you got it. Okay. So, primary survey. A, B, C, D, E. So interesting. Does anybody remember from our very first lecture years ago how we kind of talked about this, right? We had all the letters. Well, in trauma, this is the primary survey, okay? A stands for airway maintenance with cervical spine protection, precautions, okay? Let me say that again. Airway with cervical spine precautions protection, okay? So, if we think about airway and the fact that C-spine precautions, right, are next to it, we understand the importance of it, right? Airway is king, the highest level of concern, coupled with C-spine precautions, okay? So we understand the importance of C-spine precautions, okay? B stands for breathing and ventilation. C stands for circulation with hemorrhage control. Let me say that again. Circulation with hemorrhage control, okay? So again, why I'm saying it like this, right? Why am I saying this is that we have to look at A before we can move on to B, okay? Before I can move on to C, I have to fix B, okay? So we have airway with C-spine precautions. B is breathing and ventilation. C is circulation with hemorrhage control. D is disability. That is talking about our neurological status, okay? And then E is exposure/environmental control, okay? This means completely undress the patient, but also simultaneously prevent hypothermia, okay? Anybody been in a trauma room before?
Yes.
Yeah.
Okay, what's the temperature usually?
Cold.
Cold?
Hot.
I don't know what trauma room you're going to, but normally it's blazing hot, okay? I hope that they turn the heat up, because
We were just there last week.
And I was hot, and I was like, oh, it's hot in here.
yeah, it is blazing hot, for goodness sakes. When we've got cannulated people down there, it's my worst nightmare because it's so freaking hot down there. So they have the heat on, basically. Why? Because they are exposing patients, and we don't want them to become hypothermic. Why? Because people bleed more when they're hypothermic, right? Do we want a trauma patient who's already at risk bleeding more? Absolutely not, okay? So what is a quick 10-second way you can assess this? Quick, 10-second way. A, B, C, D, E. What do you think?
Introduce yourself.
Yeah, introduce yourself. And ask them what their name is and what happened, okay? So again, really quick, what happened? What's your name, right? So A, for them to be able to answer you, they have to generate air. That means that their airway has to be patent, right? For them to be able to tell you what happened, they're not hypoxic, so their breathing and ventilation is hopefully okay. And then for them to discuss the situation, I got hit by a car, right? I got run over, whatever. Someone hit me, okay? I was involved in a motor vehicle accident. Tells them that, and their alertness tells you D, right? Their neurological status is intact. So that's a very quick 10-second way to assess this. Usually that's not the case. Usually you have a lot more involved in this, okay? So airway, you're looking in the airway. You're assessing that it's patent. You're suctioning it, you're looking in it, and we're assessing if you have any sort of fractures here that can cause an airway obstruction. Okay, facial mandibular fractures can cause an airway obstruction. So again, you have to fix it before you can move on. Okay, so if you don't have a patent airway, you need to get one. Okay, you need to get one. How would I get one if I didn't have one? ET2, OPA, sure. In the interim, you could put in OPA, but we know that probably they're going to buy themselves an ET2, okay? Or you're gonna suction it out and then all of a sudden your airway's patent, okay? C-spine precautions are going to have their C-collar on. They're probably going to be on a backboard, okay, immobilized, okay? B, for breathing and ventilation, how am I assessing that? How am I assessing that? What do you think? Yeah, chest rise and fall. Is it equal, right? Is it equal? Do I hear breath sounds, right? Do I see outward injuries? With the primary survey and trauma, a lot of times it's looking, guys. It's looking and looking for injuries, right? When we talk about adjuncts to the primary survey, that is truly how you can assess someone's ventilation, but you can also just look and see how it's going, okay? What about C with circulation and hemorrhage control? How can I assess that? Really quick. How can I assess it? Yeah, color of the skin, right? Are they pale? Are they diaphoretic? What else? What other things could I assess to tell me about the circulation and if they're bleeding?
Pulse rate.
What?
Radial and or peripheral pulse rate.
Okay. Pulses, sure. Okay, perfect. What else? What? That could help us a little bit, but that could be a late sign. Remember, when someone's bleeding, they're going to be tachycardic, right? They're going to be tachycardic. That's the first sign. Sometimes blood pressure takes a bit. Cap refill. Okay, what about level of consciousness? Right, level of consciousness, most sensitive neurological indicator. Okay, if they're altered, that tells us that our cerebral blood flow is hindered, right? That could tell us that we're bleeding, okay? If they're bleeding outwardly, you're putting pressure on it, right? But oftentimes with trauma patients, the bleeding is happening internally, okay? So again, before we can move on, we gotta fix C, right? We gotta fix C. So real quick, right, let's do a quick review about hypovolemic shock and hemorrhagic shock, okay? So what things would I want to do? I've discovered that they have bleeding, right? What would I want to put in the patient to help with that? What? Okay, so am I just laying the fluids on them and hoping for osmosis?
Oh, 2 large boys.
2 large bore IVs, thank you. 2 large bore IVs, okay, what else? What kind of fluid am I giving them?
Crystalloid, which is.
Okay, initially maybe crystalloid, but I'm having someone run where to get blood. Yes, remember, you need to replace the blood. You're not bleeding crystalloid. You can hang that initially, but you know within minutes you're hanging blood. Okay, O-neg, right? O-neg. We're just gonna go with that. O-neg, okay, is what you're hanging. And is it cold or hot that or warm that you want to do? Warm. Okay, so you're hanging warm blood. Okay, excellent. Because again, we need to fix this, and then depending on where the bleed is, they could be going to surgery, right? Depending on where the injuries are and where the bleed is. But in the meantime, you're putting in those large bore IVs and you're helping to control, give back the blood. Okay. Does that make sense? D is disability. What are my neurological status? What's a very quick way that I can assess that? Very quick way.
Looking for injuries, obvious injuries.
Okay, but neurological status. How am I assessing the D? What? Okay, so are they oriented? Sure. How about pupils? Super quick way, right? Check their pupils, and then remember we talked about last time GCS. Okay, eye movement, verbal response, and motor response, right? Eyes, verbal, motor. Super quick, down and dirty. Less than 8, what am I worried about? Airway, exactly, okay? So again, in trauma, you want quick, down and dirty. You want to be able to assess the GCS and pupils, okay? Obviously, if you were to go assess them and they're posturing, right? They have abnormal motor response. That tells me what? What does it tell me? Yes, thank you, Lacey. Yes. Yes, they've had some sort of neurological insult, right? So, what's worse, decorticate or decerebrate? Decerebrate, exactly. Okay, decerebrate is towards the core or away from the core? Away from the core, exactly. Okay, so again, we have to make sure we are assessing disability neuroexam before we intubate them. Okay, try to, if you can. Sometimes it's hard, sometimes, because again, that sedative and paralytic that you're giving the patient is going to alter their neurological status. Okay, and then E, you are exposing the patient and hopefully preventing hypothermia. Why are you exposing the patient? Why is that important?
You assessing for injuries and.
Yeah, injuries that you can't see, right? Absolutely. You're assessing for injuries that you cannot see. So our clothes are off. No modesty in the trauma bay. Okay? Let's do this question. Did everyone sign in?
I didn't know.
You did not. Okay. I was feeling like I didn't. The numbers weren't. The math wasn't mathing. Okay, great, perfect. Yep. Now the math is mathing. Excellent. Okay, you guys ready to discuss it?
Sure.
Okay, great. Look at all that green. Okay. An unrestrained driver who sustained multiple traumatic injuries from a motor vehicle crash is transported by AMBO to the emergency room. Which of these actions is correct concerning primary survey of this client upon arrival to the ED? Primary survey is only completed once. Is that true or false? False. It is completed over and over and over again. Primary survey includes a cervical spine x-ray study to determine the presence of a fracture. False. That comes later. Primary survey is done quickly in the first few minutes to get a baseline assessment and establish priorities. True. Yes, true. Primary survey is a methodical head-to-toe assessment identifying injuries and treatment priorities. What does that sound like? What kind of survey is that? It's the secondary. It's a secondary survey. Okay, secondary survey is a methodical head-to-toe assessment. Okay, so again, primary. This is it. First few minutes, they hit the door. Someone is starting the primary survey. Okay, and you are establishing A, B, C, D, E. Okay, you are fixing it before you move on. Okay, fixing it before you move on, and you better believe that you are re-evaluating it. Do I still have an airway? Are they still breathing and ventilating? Have we gotten, how is their circulation? Are they bleeding more? Have they sprouted new bleed? Okay, disability, what's their neurological status? Has it changed? Okay, E kind of goes on with just making sure that we prevent hypothermia. Okay. So adjuncts to a primary survey. Professor Blur, what is an adjunct? You're an adjunct. I am an adjunct. I'm a helper, right? I'm a helper to the college. These are thought of as helpers to the primary survey, okay? What do these include? What kinds of things do you want to have help to identify primary survey priorities, okay? Primary survey priorities. So with breathing and ventilation, what other diagnostic tool would you like to make sure that the patient is adequately breathing and ventilating? So think diagnostic tools, guys. How can I assess if someone is breathing and ventilating? How am I looking at their vitals? Right? What things do I want to place on them to assess their vital signs? Am I just guessing what their blood pressure is? I'm just guessing what their heart rate is by looking at them? You do a lot when you assess someone by looking at them, but sometimes you need extra tools to help you. Okay, great. So we have some ECG. I'm going to hook them up to the ECG, right? So I can see what their heart rate is and the rhythm. Super important, right? Because I want to make sure and assess, are they having any sort of dysrhythmias? Okay. Pulse ox. Great tool to see if they're breathing and breathing. They're oxygenating, right? Ventilating and ABG is going to be very important, right? I love that. Some blood pressure, sure, blood pressure cuff. I love it. To make sure that we have a blood pressure, that's perfect. Pulse ox, ABG. What kind of catheters do you think that we should put in here? I don't see anybody that put it, but it's okay. It doesn't seem like it's a primary survey thing. What? Okay, IV catheters, sure, absolutely. IVs are always important, 100%. But what other catheters? Foley, urine output, yes. Okay, absolutely. We want to make sure there's urine output, right? That would be important when we are having hemorrhage with circulation with hemorrhage control, right? We want to make sure that we are assessing that. And then what would be another catheter tube that we would want to put in, maybe? That could be helpful to identify C. So you said urinary, that's great, love it. A-line's gonna do blood pressure, okay, sure. Sometimes they don't do that in the down in the trauma room. Sometimes they do that up in the ICU. What about, do traumas happen out in the world where they could have just gone to in and out?
Oh, an NG or OG too.
Yes, a gastric tube. Okay, it's twofold. It's a twofer. That's why it's part of the primary survey. It's a twofer. Okay, a gastric tube, either OG or NG, is going to help evacuate their stomach, decompress it, to help prevent aspiration. And then the other thing is that it could also assess if they're bleeding, right? It could assess if they're bleeding. So you evacuated whatever they just had for lunch, and then you could also assess bleeding. So within adjuncts to the primary survey, we have ABGs, we have pulse ox, we have ECG, so think vital signs, blood pressure, the catheter, urinary catheter, gastric catheter, all things to help us with the primary survey. Helpers, if you will, helpers, okay? There's another diagnostic tool that they do, it's called the FAST, where they take an ultrasound to look at the belly, okay, to see if there's bleeding. Again, that's part of C, right? Circulation with hemorrhage control, okay? Again, later, right, after we do our ABCDE, they're going to buy themselves a trip to the CT scanner where they're going to have a head to crown, or crown to crotch CT scan. Head, chest, abdomen, and pelvis, okay, to help look for other injuries. But first, we're stabilizing them and working on the primary survey, okay? Questions about adjuncts to the primary survey? Okay. Secondary survey. Gosh, so many surveys. What does this include? What is the secondary survey? This usually happens in the ICU. This usually happens in the ICU. Okay, great. So this secondary survey does not happen until the primary survey is complete, resuscitation efforts are underway, and vital functions are normalizing. Let me say that again. The secondary survey does not start until the primary survey is complete, resuscitation efforts are underway, and the vital sign functions are normalizing, okay? The secondary survey, again, I said it happens in the ICU, which is normally the place where it happens, right? Is that methodical head-to-toe assessment, okay? Who remembers block 1? I know, that was years ago, right? Block 1. I'll never forget my very first time I was teaching. Back in the day, I came and I did a block 1 lab where you guys had to do your assessment. And, you know, I feel like my assessment in the ICU is pretty thorough. You know, I kind of told you guys about it, right? And I remember we had like other students, or like, what is it called, volunteering to be the patient, right? And the person started looking in their hair. And I was like, what is happening? I'm like, what are they doing? And they're like, this is part of it. We're looking for lice. And then they like take their pen light, they're looking in their nose, their ears, and I was like, holy moly, this is very in depth, right? Again, I'm not throwing shade. I just did not realize the in-depth assessment one is taught in block 1, okay? But why I bring that up, again, is because we are going to revert to block 1 for this head-to-toe assessment. You guys, this is the most thorough head-to-toe assessment you could ever do. Because you can think about, right? I have a lot of hair, right? There's many people in here that have a lot of hair. Do you think that back here I could hide lacerations? I could hide contusions, right? And so again, that methodical head-to-toe assessment, you are doing that. You are going through someone's hair and head to look for injuries that you may have missed, okay? You are looking in their ears with your flashlight. You are looking in their nose. You are palpating. It is the most thorough head-to-toe assessment one can do. Why? You're looking for those hidden injuries that you did not see, okay? So this is a methodical head-to-toe assessment. I love that someone put here, allergies, medications, pregnancy, last meal, event. What does this stand for? AMPLE. Okay, ample. So this is where you're getting more information, okay? Primary survey is stabilizing the patient. Those priorities of care, the kings, right? A, B, C, D, E. A with airway, or excuse me, airway with C-spine precautions, right? This is where we find out all the other injuries that we missed. Oh dang, they have a broken toe. Oh my gosh, they have a fractured wrist. We didn't see that because that's not life-threatening, but this secondary head-to-toe assessment is where we find those other injuries, okay? Oh gosh, we missed that they have a zygomatic fracture, okay? That's where we find those other injuries. Does that make sense? Okay. Questions about that? Okay. All right, so this is where we're going to break into groups again. Yay for us. Okay, so we have, let's see, how many, let me just write this down really quick. Do you guys need to take a break, or are you okay? You're okay? Great. You want to talk? That's good. Okay, so let's see, we're going to do thoracic. I don't know if I spelled that right. Thoracic trauma, long bone trauma, and then I have pelvis trauma. Yeah, I already did that. Okay, so I want you to split into 3 groups. You figure it out, okay? I think there's 17 people, so figure it out. One group is going to take thoracic trauma, one group is going to take long bone trauma, and then the other one's going to be abdomen pelvis trauma, okay? So should I just split you guys up since you're all just staring at me? Okay. Great. So let's see, let's do you guys. Okay, you guys are a lot of people here. Okay, so you guys join these people over here, okay? And I want you to do thoracic, okay? You guys do long bone fracture, okay? You guys do abdomen pelvis trauma. Okay? So, what I need you guys to do is I need you to nominate someone to type. Okay? You're going to type a document, okay? And what it's going to include, I'll come around and tell you things that I want you to focus on, but I want you to type it so that all of our friends here whose brains are a little bit fried can utilize these things to study later on, okay? So I need you to nominate someone to type, and then afterwards you will email it to me, and I will post it so all of your friends can use this to study, okay? Questions? No? Okay, so let's do like 20 minutes since we are typing, and then we'll talk about it, okay? 15 to 20 minutes, okay? So, you guys are my thoracic people? Okay, so what I need you to include in your thoracic is flail chest, okay? You need to look that up, flail chest, so go ahead and write that down. You have to be including pneumo, like like a simple pneumo, regular pneumo, and then a tension pneumo, which should be kind of a review, right? And then also pulmonary contusion. Okay? Questions? No? Great. Okay, and then long bone?
Yep.
Okay, so, focusing on femur and humerus. Okay. Oh, also, within your topics, I need you to tell me which part of the primary survey you're most concerned about. Which one you're most concerned about in regards to your trauma, okay? So, humerus or long bone, okay? I want to talking about